You could help support the One Thing podcast by visiting our affiliate sponsors. I've teamed up with Healthgevity, which is a company that I learned of over the last several years. I really enjoy what Healthgevity is doing. They've revolutionized the wellness industry by providing the finest quality and most effective nutritional products for ultimate health span. They work in tandem with doctors, patients, and researchers to design real advanced formulas that, frankly, I have not seen done on this level before. Please visit them and see what they have to offer. If you find various products that you're interested and you're looking for a discount, you can enter in the code ONETHING, all one word, one thing, for a 10% discount. This will not only provide you access to excellent health supplementation products, but also will help support the podcast. Thank you so much, and I appreciate your support. There is always a reason for illness. You may not have all your answers today, but that doesn't mean answers don't exist. Never give up. These are the words of today's guest, Dr. Dianna Driscoll. In this episode, I discuss postural orthostatic tachycardia syndrome with Dr. Driscoll. She shares her personal and professional journey with postural orthostatic tachycardia syndrome, otherwise known as POTS, and its related illnesses. After years of worsening health and little validation from the medical system, Dr. Driscoll took matters into her own hand, combining expertise from her years working as an optometrist and applied them to her lived experience as a patient and caregiver. She developed what became known as the Driscoll Theory, uncovering key mechanisms related to POTS, including intracranial pressure, acetylcholine, vagus nerve dysfunction, and systemic vascular irregularities. This conversation explores the emotional toll of navigating invisible illness, the gaps in conventional care, and the framework Dr. Driscoll now uses at POTS Care and in her patient community, POTS Rebels. Along the way, she highlights both practical interventions and hopeful perspectives for patients and practitioners alike. I hope you enjoy this episode as much as I did, and please share this episode with your friends and anyone suffering with this condition, as it's very helpful to hear these perspectives. Thanks again for being here, and I hope you enjoy this week's episode. Dr. Driscoll, welcome to the One Thing podcast. It's a delight to be here with you today.
Thank you for having me, Dr. Rindy. It's really an honor to be here.
Thank you. You're very welcome, and it's an honor for us to be able to speak with you. I've been following your work for a while, and I'm excited to hear your approach firsthand. It's just very interesting work that you do. I know that you've had a long journey with this process personally and professionally. We're going to be talking mainly about POTS and how it interweaves with chronic illness. So I just curious is to get started in your own process professionally or maybe personally, when did you start questioning just sort of the medical system and kind of general approaches and saying like, I need to start figuring out some of these conundrums or complexities myself because the typical model wasn't working for you?
Yeah, that's such a good question because it was actually one day a decision I knew I had to make. And it was just a terrible day, frankly. I was diagnosed with POTS, as you mentioned, and went through about 3.5 years of working with doctors. I assumed they knew what was going on and I just needed to follow what they were recommending. I participated in Mayo Clinic's clinical trials for 3 years. And I was getting worse every year. And I thought, they must know something. They're just not telling me. Right? So I sat down with them that third year and said, okay, I am still completely disabled. My son is disabled. He was sick for 3 years. And I said, what do you guys really think this is? I mean, where should I be looking? And they said, oh, well, we think POTS patients are perfectly normal. They're just more aware of their own bodies. And that was the moment where I thought, I'm on my own.
Yeah.
They don't have any idea. I mean, I got a virus that other people got this virus and I just didn't recover. And it was 2 weeks later, I was disabled. It wasn't subtle. It wasn't something I could push through, I was a strong woman. And my son was 8 years old when he got sick. He sometimes couldn't even sit up without fainting. It was beyond discouraging. But I thought, okay, I'm an optometrist. I'm in the medical field. I'm in the body of a patient. I have children who are sick. Let's give it everything we got and see if we can get some answers. Yeah. And it was still 10 years and many layers of figuring it out. But there was that moment. I will never forget that moment. Yeah.
Yeah. I mean, so the world of POTS really, from a specialty standpoint, comes down to, having support from autonomic neurologists, sometimes cardiologists, and they're very rare, hard to find people that really understand it. So were you on your own, just like pouring through research, or what was the...
It was 24/7, honestly. I had a cardiologist who ruled out heart problems. That's great. And I got to say that the vast majority of practitioners, I mean, including me, had I not gotten sick, hear the word POTS and think postural orthostatic tachycardia syndrome. That's a heart problem, right? Well, after seeing thousands of patients, I will have to tell you, we have literally never had a patient whose cause of POTS was a heart problem.
Mm-hmm.
So that label alone is a problem. But it was important, and we always make sure our patients to see a cardiologist, rule out things that are, atrial fib or PVCs are common or that sort of thing. Rule out that sort of thing, but it's not the cause of POTS. And then I had a neurologist whom I loved, and he didn't understand any of that. Just nothing. But he hung in there as I was very slowly working through the problem. And he just hung out by my side and supported me. And to this day, he's a huge source of support. So, and now he understands what happened, what we went through. So those are the two doctors I think I kept for just mainly support. But it was basically on my own, which is not a good place to be.
Yeah.
Frankly, I was running my own blood tests and et cetera, and trying things, but it had to make sense to me. I refused to believe that this was something that we couldn't recover from. And I didn't want to treat it symptomatically. I knew something happened, right? And whatever happened, could we undo it? And I'm healthy again, And then my kids were so sick. Just nothing made any sense.
Mm-hmm.
High salt or blood volume enhancement or even beta blockers made no sense. They use oftentimes beta blockers in POTS to slow the heart down. And my heart was racing, especially when I was vertical. I had what Mayo called a flaming case of POTS. And I said, okay, can you give me a list of the things that would cause a racing heart like this? I said, no, we don't know that. I thought, well, why don't you know that? You're a cardiologist. Don't you learn the things that would cause, this? No, we don't really know that. We just can slow it down. And that just didn't seem like the right approach because I was sick from head to toe.
Mm-hmm.
I said, can you ignore the heart rate? That's the least of my worries. Everything else that's making me disabled, a fast heart rate isn't going to make you disabled. I said, no, because your label is POTS. So we have to focus on the heart.
Mm-hmm.
Very frustrating. Yeah. So had to go it alone.
Yeah. So it's interesting when something doesn't fit within those organ systems that conventional medicine has defined, say cardiology, gastroenterology, neurology. You have a condition that overlaps multiple specialties, and it's, more of a functional systems-oriented problem, I should say.
Right.
How did you go about developing the framework? How did it start? And obviously it ended up becoming, sort of the Driscoll Theory. And I'm just curious that process of...
Yes. The Driscoll Theory, which, by the way, I will share that with anyone who wants it. That is absolutely no problem. Happy to do that. I first put that out in, 2012. So we've moved far beyond that, but I think it's still at the forefront for most people. But one of the first things I figured out was, again, just personal experience. One issue with, and that's the majority of patients diagnosed with POTS, is there's a propensity to develop high intracranial pressure. That is treatable. And as eye doctors, that was one area I was fairly comfortable with. But it doesn't exhibit as what we would typically see. As eye doctors, we usually look for a swollen optic nerve. It doesn't exhibit, called papilledema. It doesn't usually show. The MRIs sometimes will give hints of that, but not always. So idiopathic intracranial hypertension without papilledema is the thing. But as clinicians, we forget about it. And as patients, we go to doctors so incredibly ill, and they're not necessarily tuned into those symptoms. And the number one symptom we see with that is more neck tightness, discomfort at the base of the skull, not so much headache as we learn in school. So, but figuring that out and treating it was like, oh, thank God, that helped. So that was hugely helpful. And IIH, when it occurs, it's always a secondary problem. Okay, it's a significant one, but something's still driving it. And then as an eye doctor, I thought, we can't all be having normal blood work, everything looks good and be this sick. Where could we look in the body to help figure this out? So my comfort spot, Adam, was in the eyes, right? So one of the first studies I did was gathered a bunch of patients and a bunch of age-matched normals. And we did all these ocular tests on them. I was the blinded doctor, meaning I was presented with images of the back of their eyes, patients or not patients. And I wasn't told who was who, and I had to guess who's a patient and who's not. I had no idea what to look for. So I just considered everything. I thought, okay, well, this is a little weird. I guess as an eye doctor, we wouldn't call it. I'd probably blow right past it. But I started to see patterns, and those patterns were a huge clue into some of the problems. The patterns included some irregular optic nerve margins, perhaps suggesting mild idiopathic intracranial hypertension, that possibility. The other one was the vasculature. And the eye, of course, is the only place in the body we can look directly at blood vessels. We don't have to look through tissue or anything. And I was looking very closely. And there is a tendency in the patients to see the arteries were a little bit smaller. There is premature atherosclerosis, plaque formation, even like children with POTS. And the veins tended to be larger. And importantly, the caliber wasn't always smooth. It was irregular. And ultimately, I was able to figure out that's mild fibrosis or scarring. Could patients with POTS be subjected to chemicals throughout the bloodstream that's damaging the vascular endothelium? And if so, what the heck is that? And then what other problems is that causing, et cetera, et cetera. So quite the journey, but those were two very important things to figure out.
Wow, that's such an amazing connection, and the fact that it landed in your area of specialty.
Would you call that luck?
I don't know what to call it.
Right, I don't either. I thought maybe divine intervention.
Yeah. At least, sometimes we choose our specialty, and sometimes it's chosen for us.
Isn't that the truth? I definitely did not choose this.
Yeah. So at that point, that's such a big piece of this puzzle. Your work bridged into the vagus nerve from there. But before we go into that, I'm just curious, you're not feeling well. You're trying to save yourself. You're also trying to save patients and, your son. And what's the emotional toll like at that point of your life?
That is such a good question. I think one of the hardest things about this condition, frankly, is the lack of validation patients receive. I couldn't believe that I could be that sick and be told, oh, maybe it's your hormones, or maybe you need to meditate. or maybe you're just more aware of your own body. You've got to be kidding. It was so dismissive. And to not have other people understand why you can be so sick, every system of the body, it would wax and wane, at least initially a little bit, which really confounded people. But I didn't have someone I could lean on, say, oh, I get it. This is really bad. I tried to go on forums for POTS and things. Those are brutal because everybody was sick. Nobody was really getting answers. And then our brain starts to be affected. You have these short tempers and things would flare. And I thought, I think I'm just getting sicker being around this. That's not a good option.
Mm-hmm.
But I look back on that now, Adam, and I see that was probably necessary. Because if I had had someone I could have leaned on, I would have just leaned. And I think someone could have been with me 24/7. It would not have been enough.
Mm-hmm.
So instead, I was forced to just basically buck up, suffer through it, try to keep my wits about me, use my brain to try to figure it out because I had no one else to lean on. So again, one of those things I may not have chosen to do that, but that was the situation I was in. And if it hadn't been just that situation, I don't know that I could have gotten there.
Yeah. And also, see if you agree with this, but I mean, when you have a child that's also going through something, there's some magical strength that you find. It's like a different gear that you didn't know you had. I don't know if you experienced that.
Oh, absolutely. We can feel weak and scared, et cetera, but we can't present that to our kids. But my son came to me when he was about 9 years old. And he said, you don't understand, Mom. I don't think I can go one more day. The suffering could be so intense. Sometimes it would come in these waves. I call them episodes. And I, as an adult, could barely get through those as a child. But at that point, we had no answers at all, nothing. And all I could do was validate him and tell him, I know he's suffering and this is really bad, but I'm going to give it everything I have to try to figure this out, figure out what happened to us and what we need to do to get healthy again. And that was enough for him to give him peace, to just keep going. But a terrible position for patients. And I recently set up a Patreon account called POTS Rebels that we meet every week or two on Google Meet so we can actually talk. And I want it to be as a source of support. It's a safe place. There's no wacko science in there. And the patients can have that reassurance from, a recovered patient too. I would have loved to have talked to someone who had actually recovered from that beast. So it is a terrible place to be. This should not be happening. There is no reason it would take an optometrist from Texas, to figure some of this out. But it's very complex and every case is different, making it harder.
Mm-hmm.
So,
well, thanks for sharing that. Obviously, you wouldn't choose it for yourself. At the same time, I'm sure the reward that you've had for helping lots of people and helping people get through this and educate people has been, substantial. So
it is. It's a passion too now, because as soon as I talk to someone going through it, those memories of how horrible it was just come rushing back. And you want to do anything you can to help them out of that. And it takes time. It's difficult. So to be there to support while they work through it that's what I'm here for.
Great. Well, let's get into some more of the mechanisms of what's going on with POTS. I mean, from a high level view, before I had mentioned, I wanted to get into the vagus nerve connection. Mm-hmm. I think that's such an interesting topic. But from a high level view, just kind of diving into the mechanisms of POTS, like what is it? And what's the initial push?
Yes. And that's a big question. But I try not to miss out too many important points. First, I think POTS is a problem because it's not a heart problem. It kind of implies that it is. And I think disorders affecting the autonomic nervous system are bigger than just the people who meet this arbitrary criteria for POTS, right? So Right now, I think the criteria is like heart rate needs to go up 30 beats a minute on a real tilt table test over 10 minutes for a certain age group, blah, blah, blah. And someone just chose that number out of the air, I guess, which makes no sense to me, because I think instead we should be thinking bigger and look for patients who tend to develop a fast heart rate upon standing and present with the patterns of illness that we see.
Mm-hmm.
And that's where the diagnosis comes in. So there are commonalities among patients, and the commonalities among POTS patients are kind of similar, if not the same, to some of these commonalities in the ME/CFS world. I studied fibromyalgia, PTSD, which is interesting, mild traumatic brain injury, autism spectrum. We see this family of quote invisible illness, and they fit certain patterns. To me, that tells us this is where we need to start looking. And one commonality that I think is very important is the commonality of, could the patient be having fast heart rate or a tendency for fast heart rate because the heart is reacting properly to a stimulus? And this stimulus could be an inflammatory stimulus.
Mm.
For example, if we get the flu, doctors know to look for tachycardia to help them diagnose the flu, because it's a proper, if you will, response to the heart to some of that inflammation. So think of something like the flu, but it doesn't really go away. The inflammation continues. The heart continues to react. And then what happens to the rest of the cardiovascular system, vascular being important, and then what other systems fall down from that? So inflammation is a huge, huge problem that it's very difficult to diagnose, because the traditional markers for inflammation, CRP, sed rate, are oftentimes perfectly fine.
Mm-hmm.
And as practitioners, we learn in school that if those markers are fine, the patient doesn't have inflammation, and that is wrong. So again, one of our first studies was a complete panel of inflammatory cytokines. I just had a feeling that inflammation was going on. And I think this is kind of the patient feeling that sometimes you just have to listen to your intuition.
Mm-hmm.
When I was sick, I was taking ibuprofen a lot. And somebody asked me why I was doing that. I said, I don't know. I just feel like I need it.
Mm-hmm.
I put a pillow behind me in the car, and somebody said, why do you have that? It's like, I don't know that either. But I was a feeling I had, and I looked at this panel result for patients, and some of the markers were like crazy high,
Mm-hmm.
like 20, 30,000 times normal. Their CRP or sed rate was fine. And I thought, you can have some forms of chronic inflammation. Those markers aren't picking it up. So where do we start with that, right? A huge, huge question. That is one commonality.
Mm.
Mm-hmm.
So with the heart rate being more of an adaptive, maybe regulatory shift in response to inflammation.
Right.
So did you find anything peeling back further, the drivers of that inflammation, whether it's, I know that the viral etiology has been well explored. Is that where you landed?
No. And I think we have to be real careful, and we teach our people, at POTS Care, our inclination is to look at the trigger, be it viral or mold or Lyme or whatever. But that's not the problem. The trigger is usually gone. But instead, look at the body's abnormal response to it.
Mm-hmm.
And that is what is persisting. So our work focused on everything from genetics to it, to did it lose the neurological control? And that's where the vagus nerve came in. What receptors are on the heart for certain inflammatory chemicals? So just starting with antihistamines, frankly, helped to block that one chemical.
Mm-hmm.
Helped because we knew the vasculature was affected, and the histamine 1 receptors are on the blood vessels. And then histamine 2 receptors are in the gut, and interestingly on the heart. So blocking that also helped. But again, just kind of a start. The vagus nerve is the nerve that normally would control inflammation, and it was becoming obvious that something was up there, right? I certainly was not atypical in developing constipation. It went to full-on gastroparesis. I had intermittent diarrhea, which I was really excited about because at least it would relieve the constipation. And my gallbladder failed. I mean, it just failed. They said the ejection fraction was almost nothing. They wanted to remove it. And I said, okay, tell me about that. Is it infected? Like an appendix? Is it about to blow? And they said, no, it looks okay. I said, is the opening stuck? Maybe something's blocking it, a gallstone or something you can't eject. They said, no, the opening looks fine. But this sounds neurological to me. And if it's neurological, if there's any way I can fix this, I'd like to keep that organ. I love cheese. Life is easier with a gallbladder. And I remember how upset the doctors were. Turned out to be a smart move. My gallbladder works great. But that was the neurology speaking. Yeah.
Yeah, I love how you point out that the trigger is long gone, because I think that's often a confusion in people who think of this concept of treating the root cause. And
yes,
that term can get distorted and lead people down like a unreachable target. So I think that's really great. And you're looking at sort of the secondary aspect of whatever the initial shift was, and then also looking at points of leverage where you can actually shift and help the body restore balance, which, I mean, that's very action oriented and, give us some tools to work with, right?
Well, it made sense to me. Again, it's just the position I was in. My kids were sick and they didn't get the same virus I got. My son got 2 regular old viruses, at school that everybody else got. Each one knocked him down further. And my husband at the time was fine. And he went through illnesses just like the rest of us. So I thought, we're responding differently. What is that about? So yeah, it's very easy to focus on infection. And I think it's important to remember when inflammation goes up, the immune system tends to go down and dormant viruses show up. Like my Epstein-Barr was through the roof. And I remember thinking, this is the cause of the illness. And the doctors saw that result. And I remember them saying, I don't think so. And I thought, why would it be so freakishly high? If that wasn't the cause. No, they were right. That wasn't the cause. But we can see every dormant virus show itself again. We know from the research in chronic fatigue syndrome that if we approach it with just purely an antiviral approach, they don't recover.
Right.
That's not the way to approach it. If we approach it from the inflammatory side, those dormant viruses take care of themselves without any help from us.
Great.
Yeah. So the way the body's meant to take care of it.
So with the vagus nerve being involved, it would be great to hear your take on the way the vagus nerve plays a role in inflammation balancing.
Yes. Well, that wasn't my research on figuring out the inflammatory effects of the vagus nerve. Other people figured that out, which was great in the late 90s or so. But at the time, I was thinking, could the vagus nerve be damaged? It's very easy to damage it. It's so long, it goes from the brain down the neck. I was thinking, was it compressed at the neck? I had abnormal blood vessels pushing against it. Maybe it goes into the chest and into the abdomen. Anyway, along that route, it can become damaged. So what I did was I sent out symptom checklists, and I did this over 5 years. And I sent them to chronic fatigue patients, POTS, fibromyalgia, and PTSD. And I put, I think it was like 150 symptoms. And in those symptoms, I talked about 35 symptoms of anticholinergic poisoning or syndrome. And the majority of patients had the majority of those symptoms. They would wax and wane because they hadn't been poisoned, right? But it clearly indicated the problem wasn't likely the vagus nerve itself. It was a bigger problem. It was a neurotransmitter problem, and it was affecting cognition. It got so bad for me, I couldn't stay awake even. I went from severe insomnia for years to severe, basically narcolepsy. Mm-hmm. I was awake an hour and a half maybe in the morning, an hour and a half at night. I was struggling during that time. And then you can see with patients, the pupils get bigger. They get much more light sensitive. Ultimately, their eyes get dry. And that's not vagus nerve. That's acetylcholine. So we were dealing with something that was affecting the neurotransmitter. And then I had to kind of pick through that problem, right? I thought, if we have a problem with that neurotransmitter, how can we help? Or some people could have a damaged vagus nerve for any reason, infection, trauma, whatever, how could we help them too? And I was forced into having to figure it out because the gastroparesis I had went to 100%. I could not have a bowel movement. And it had been almost 2 weeks. I'd been to the emergency room. I went to a surgeon, every doctor that I thought could maybe help me. I tried everything over the counter. I was getting to the point where I was afraid I was going to blow up,
Mm.
And that was actually a necessary part of it because ultimately I was forced into figuring it out myself. And I thought, okay, if this is a problem with that nerve, do the receptors of the nerve still work? And I remembered in optometry school learning these nerves and taking notes because I was a total geek. Remembering there's 2 parts to that nerve. There's the long preganglionic portion, and there's a gap or synapse. Now there's a tiny postganglionic nerve. And I remembered the instructor saying, the postganglionic nerve, it's so small, it's almost a part of the organ itself. I thought, as far as I know, even if I damaged my nerve, I should hopefully still have that postganglionic nerve. Could I stimulate it? So I remember the neurotransmitter is acetylcholine. I thought, okay, that's not a drug. I can't use that. The body breaks it down. What is the agonist or mimicker? We also learn agonists to all these neurotransmitters in school. Well, that's easy. The vagus nerve is the only nicotinic nerve in the body. The agonist is nicotine. So I got a nicotine patch and I put it on my abdomen. Had a bowel movement. It's like, what? Had one the next day and the next day. But in a few days, it was so inflammatory. It looked like I was being eaten alive by fire ants. I couldn't continue that. And then learning that it was a bigger problem, it was a neurotransmitter problem, I set about trying to create a supplement because I didn't want to have to wait for a new drug, that would come together in just the same way that nicotine would do and stimulate that postganglionic nerve. Great. But it would also cross the blood-brain barrier to support acetylcholine for the brain. It covers for every genetic defect in the acetylcholine pathway. And I'm very proud of that work. That is my geek speaking. It had to be already approved by the FDA as the ingredients had to be safe. And I wanted to make sure that the eyes responded because the pupil size and the tear production is not a nicotinic response. That's a muscarinic one. And nicotine won't help with that, right? So came up with what's now ParaSym Plus, which has been a godsend for people. And I never wanted to get into the supplement industry. I never did. It makes it sound like you're a snake oil salesman. I was just at home making it for my kids and I for years. And the reason I decided to put it out there was once I stopped it, I developed pancreatitis, and that's potentially severe. And it reversed it within days. But we've got to get word out. But again, a bigger problem than vagus nerve. Nicotine is a very poor choice for treatment. It was great for me for diagnosing the problem and looking to see if the receptors were still viable. But it's more of a global issue. So, and until I could figure out what the heck happened to the neurotransmitter, at least I could put it back. And we could keep the neurology working. And the organs responded, which is a miracle. The gallbladder came back. My pupils got smaller. We can show that to patients that in a couple days, they can see their pupil size change. So they know they're on the right track. They're hitting the right receptors. It's just a matter of time.
Interesting.
Yeah.
That brings up the genetic piece because it seems to me from the patients that I've cared for, there seems to be a body habitus, whether it's a hypermobile body or a body that has collagen-related issues. That's just from my view. I seem to see that thread. I'm curious where you've landed with your research genetic-wise, and since this also affected other family members, what you've learned about the connection.
And I will say, having had POTS care now for like 9 years, about 40% of our patients are hypermobile. And the body habitus you talk about is, they kind of look like me. Tend to be fair skinned, fairly tall, bones are a little thin. We just have a certain look. And the Driscoll theory initially was put out as what is the reason for POTS in EDS? Because when I was told I was hypermobile, and it was at Mayo, they looked at that. They said, oh, well, this is Ehlers-Danlos syndrome or EDS. It's a genetic disorder of connective tissue or collagen. I said, oh, okay. What gene is that? They go, oh, we don't know. It's like, what do you mean you don't know? Yeah, we can't seem to find that. I'm like, okay, how do we know it's a genetic disorder of connective tissue then? Should we be keeping our minds open to the possibility it's a genetic disorder of inflammation, and that inflammation is weakening the tissue? Or could it be both? Could a patient have a gene setting themselves up for slightly poor structure and poorly regulated inflammation? If so, what is the treatable aspect to it? It's not changing the gene. It's locating and treating the inflammation. So, although we've been deeply at work for picking out these genes, patients don't have to wait for that. Okay. They instead need to direct themselves toward what type of inflammation are they dealing with and treat it. Mm-hmm. Right. I'm still hypermobile. I'm not sick. I certainly don't have POTS, nor do I ever plan to have that again. My kids are not sick. I'm not quite as hypermobile, though. What happened when I got sick, and I hear this from other patients, I got looser. And what was happening is this inflammation surged, and it was kind of eating away at the tissue. So it ultimately caused pain, too. So the perception for hypermobile patients by other practitioners is a horrible one. They see us as weak and whiny. Hypermobility itself shouldn't cause pain, and they're right. It shouldn't. Inflammation does. And tissue, when it's getting destroyed, absolutely should. So our focus should be on locating that. And that's where it is a little bit tricky because everybody is different. But again, commonalities. So I'd say first, get the vagus nerve working. That's your anti-inflammatory nerve. That'll help, Mm-hmm. And we encourage people to look at signs and symptoms of high intracranial pressure because treating that is, oh my God, a godsend.
What are those?
Oh, it initially starts, or usually starts as dizziness, okay, which is pretty much across the board. But then you get like this discomfort at the base of the skull.
Is that the coat hanger?
Yes.
Coat hanger pattern.
100%. The muscles get tight. I would find, and it wasn't pain for me. I felt like I just had a bad pillow. I went through 30 pillows. I'm not exaggerating. I had a girlfriend who was just determined to help me. She just brought over pillows every day, and I just kept trying them out. And then if it gets bad enough, you can develop headache or vision changes. I had persistent nausea, and it wasn't like I was tossing my cookies. Praise God, I wasn't. It felt almost like I was pregnant. Mm-hmm. Just this low underlying nausea that most doctors would see that as GI. 80% of it was the high pressure. And then other things were basically invisible. It was starting to flatten my pituitary gland a little bit. And the pituitary gland is the master hormone gland. So then some of that gets wonky, right? Dramatic insomnia is very common. Mm. When intracranial pressure goes up, it activates that sympathetic nervous system. It wants to wake you up. Something's horrible is going on. I can't breathe. The brain is suffocating. You can't sleep with that. At least I couldn't. I could be awake literally for days, even with sleeping medication. They had trouble anesthetizing me. And every time we hear of a patient who doesn't do well with anesthesia, like they can't be put under easily, I think about that and wonder, could they have high intracranial pressure? Mm-hmm. They wanted to put me under for a procedure, and the nurse came up to me and she said, Dianna, I could put the entire wing of this hospital under with what I have given you. And you are sitting up talking, what the heck? And she said it like it was my fault. I told her, well, you're the expert here. You figure it out. I can't tell you why it can't be put under. That was part of it. So that sympathetic overdrive is tough.
Wow, that is a podcast in itself. It's really fascinating. And the nuance of picking that up clinically is, requires a lot of skill, I'm sure.
It wasn't easy for me. And I'm an eye doctor. We're trained to recognize it. But what we learn is not what we see clinically.
Mm-hmm.
We learn to look for headache, do a lumbar puncture. Don't do that. Patients are more prone to spinal leaks or Chiari or whatever. You're just asking for trouble. There's papilledema. We don't see that. So what we learn in school is not what we see in clinic. Mm-hmm. In clinic, we look for that coat hanger, right? Mild nausea, insomnia. Yeah.
So with the Driscoll protocol, just briefly, I'd love to just hear the overview of the pillars of the approach and where people can learn more about your framework.
Yes. And I'm so happy to share that. And thank you for asking about that, Adam. I'm at potscare.com in the Patreon account where we started POTS Rebels. I'm putting everything I can find in there. And then we eat, and that's rewarding for me, and I think for them too. But I don't have a protocol per se for treatment. Mm-hmm. In fact, I don't even like those words.
Yeah.
When I hear a protocol for some invisible illness, I go, okay, that can't be right.
Yeah.
Everybody is so different. And even my kids and I were different, and they were different from each other. Having said that, everyone's different, but the commonalities are a decent place to start. And most of those are in the Driscoll Theory, like the propensity to develop high intracranial pressure, the vagus nerve problem, which is actually a neurotransmitter problem, and the vascular irregularities, which is like a systemic attack. And that'll usually get people started. So ParaSym Plus is hugely helpful. The inflammation, no matter what type of inflammation people are dealing with, they don't have to know the type yet to get some help. Mm-hmm. If it's affecting the cardiovascular system, it likely involves histamine. And it's not a histamine problem, it's an inflammatory problem. Mm-hmm. But inflammatory cells of many types kick out histamine. And if you have inflammatory POTS, you want to block that while you work through that. At least with Zyrtec is great for the blood vessels. You don't want to stay on Pepcid AC for a long time because that can be problematic, but that's a good start. ParaSym Plus I mentioned. And then all inflammatory patients deal with oxidation. And the oxidation worsens the inflammation. It affects the blood vessels, ultimately the organs, and it changes our brain chemistry. Mm-hmm. Where we get more anxiety type symptoms, and it can exhibit like anxiety, or it can exhibit like this almost OCD, attention to detail. We're high achievers. We're at the top % of everything we do, but it can get to the point where we can't function with other people. We expect people to have the same level, of detail orientation we do, and that's just not realistic. Or patients will end up trapped in their homes or unable to make a phone call or whatever. You just can't do that. I got to the point where I remember thinking I was a successful doctor with many offices. I handled stress out my wazoo. I couldn't order a pizza. That was just stressful. The inability to handle that was dramatic. So one of the supplements on TJ Nutrition is NAC Mags, which I figured out how to increase glutathione on the brain and throughout the system and recycle the glutathione that you produce. And I just carried that bottle around with me while I was recovering. Mm-hmm. I felt kind of buzzy, adrenergic. I just took more. And that helps break that cycle of inflammation, keeping the vagus nerve working, address the oxidation, control at least the histamine, a decent start.
Wow, that's a really good foundation. I'm sure there's many offshoots and personalization from there.
Doggone it. I think as doctors, we would love to just have a label and a pill, and we don't have that.
Yeah, I feel like, the benefit of sort of the framework or the protocol for some people is at least gets them into the right area of thinking. But they definitely need to work with someone who understands the nuances because, people generally, it's not a straight line, and you need someone who's seen things go awry and help support you. So, yeah, I figured we could finish up our conversation by just hearing more about, what people are experiencing, in your Patreon group, and then also just a take-home message for people, if they're home and needing a little inspiration.
I absolutely understand that. And I think hope is such a powerful thing, right? But hope without reason for it is meaningless in my book. It's kind of like getting a label of pots. Oh, yay. No, that was meaningless, So, but hope for a reason is very important. And at Patreon, we're releasing the information. We're talking about it and talk some patients through it. But I want everybody to know there's always a reason for illness. Always, right? And you may not have all your answers at once. Most people don't. You certainly might not have them all today, but it doesn't mean there aren't answers. So never give up. I don't know that anybody got sicker than I did. And I probably should have died 5 times over. Honestly, I was just figuring things out just in time. So never give up hope. There's always another side to it, and stay in the science. I do see a fair number of patients, as you mentioned, kind of going down tangents, which we all have to go through them. But if you go down a tangent and it's not the answer, don't stay on that tangent. Exit it and move on to something else because you're not there yet. Yeah, it shouldn't be that hard, right? But yeah, there's always a reason for illness. And even if the doctors don't understand it, doesn't mean there isn't a reason for it. I feel very fortunate in that I see research facilities moving forward, and COVID has kind of helped with that. Some of the inflammatory thing, the vagus nerve thing, which really isn't a vagus nerve thing, the vascular problems, et cetera. But it is still so slow. It's painfully slow, and patients can't wait for that. I was lucky. I could move very fast because I was independent. I didn't have to work by committee. I didn't have to wait for grants or whatever. I just used my disability income. But patients who are waiting for the major institutions to come out with it, I think, are going to be sorely disappointed. We have to move faster than that. So I'm doing everything in my power to push things along quickly because patients need it today.
Well, thank you so much for being here. This was really interesting and such a well thought through understanding of, everything you've learned and pieces of what you've learned. And it was just great to hear how your mind works. And it's really refreshing to see how clearly you think through processes and really gaining an understanding of mechanisms as much as you can. Because, those are the things that feel solid, when we're thinking through these complexities is mechanisms, right? If we understand mechanisms and pathophysiology, it's like things open up, answers open up.
Yes. And things have to make sense, right?
Yeah.
I just wasn't willing to leapfrog the making sense part.
Exactly.
Yeah. So that is how my mind works.
Well, I really appreciate that. And thank you so much for being here.
Thank you for having me. Now, it's hugely important that we spread word and help. So many people are sick needlessly. It really needs to change. So thank you for your work in doing that.
Thank you so much for tuning in to this week's episode of the One Thing podcast. Please share these episodes with your friends, loved ones, colleagues, patients, healthcare providers, anyone who you feel might benefit from hearing these informative interviews. We tend to learn best from people sharing things with us. That's often the first time it's introduced. So don't hesitate if the content of these episodes reminded you of someone that might benefit from it. Forward the episode to them, and I'm sure they'll either appreciate it or be appreciative that you've thought of them. So once again, we'll look forward to seeing you next episode on the One Thing podcast. And again, much appreciation for you being here with me.